servicio de trauma del Hospital Santo Tomás. Todo esto viene porque yo la vi a ella haciendo unas presentaciones, ella hace otras presentaciones para otros grupos de estudiantes y médicos jóvenes, y yo le pregunté si tenía algún interés en que participaran en esta clase, y muy amablemente nos ha dicho que sí. El doctor Victoria también estuvo de acuerdo. El asterisco es que, como ya ustedes deben saber, aunque la doctora habla muy bien el español, ella prefiere y se siente más cómoda dando la clase en inglés. Entonces, la clase es en inglés. Sin embargo, si ustedes tienen alguna pregunta en la clase, y ella me va a hablar un poquito más de eso ahora, es bueno que la hagan en español. Y después la traducimos, porque así, si la hacen en español, aunque ustedes la puedan hacer en inglés, algunos que no puedan, para que todo el mundo sepa cuál es la pregunta que se está haciendo. Así que dice ella que yo hablo mucho, lo cual es verdad. Entonces, así que ya yo me voy a callar. La doctora vamos a estar aquí un rato y, por supuesto, pues ella les va a dar algunas otras instrucciones o indicaciones de cómo vamos a llevar la clase. ¿Me puedo sentar en alguno de estos puestos que están por ahí? Sí, ok. So yours. Si tienen, how do you want to take the questions? Away from the front or here? Pueden interrumpir si quieren hacer una pregunta.
Thank you for the nice introduction. I don't know if everybody can hear me clearly or if I have to speak louder. I will try my best. I went to the valley this weekend and I have a cold, so my voice is not that strong as it normally is. So Dr. Mon, thank you for the introduction. It was lovely. He asked me to present you about trauma, similarities and differences between Panama and Belgium. It is only a 14 to 16-hour flight from each other, but an experience abroad is invaluable to share experiences and to learn from each other. So I will start with Belgium. It is a very, very small country on the other side of the world, with 10 million inhabitants for only, Belgium is like 30,000 square kilometers. If you compare it with Panama, it's 75,000 square kilometers with 4 million people. So it's a densely inhabited country. I am from Ghent. It's one of the most beautiful, or it is the most beautiful town of Belgium. You should definitely visit it. Where we have a lot of culture, beautiful cathedrals, beautiful churches, an ancient castle in the city center. It's medieval, it's dating from the 1500s. And we also have beer, fries, waffles, and chocolate. So I hope that you're convinced now to come and visit Belgium. But we also have this, and this is a satellite photo of Belgium at night. And you can see that there is a lot of light pollution. And this is due to the high amount of roads and traffic in Belgium. Every light is standing next to a road. So it's not only a very small country, but it's also like the center of the European Union and the geographical center of Europe. So you can imagine that there are a lot of blunt trauma in Belgium. Blunt trauma accounts for almost 90% of the traumas in Belgium. And if you look at the numbers of the world, 4.4 million people die of trauma that is as blunt and penetrating trauma. That accounts for 8% of the whole amount of deaths, like the mortality, and 1/3 of that is due to traffic accidents. So trauma is something that is very important that you have to learn and to know about. If you compare this with Panama, before the early 90s, there was a lot of penetrating trauma. After that, there was an increase in construction of roads and stuff, so more blunt trauma came up. And after that, like now, penetrating trauma is rising again due to a lot of connections with narcotraficantes and links with gangs. So what I will be talking about is a bit on this slide. Lucky for us, there has been an evolution and a lot of changes in the 21st century. And one of these changes is the implementation of a trauma center or trauma system. The imaging got a lot better. There is a protocol now for massive transfusion. Damage control surgery is very important as well. And I will talk a little bit about conservative and minimal invasive approaches. So let's start with the implementation of the trauma system. This is of invaluable impact for the management of traumas. An early and multidisciplinary approach aids in the diminishing of mortality due to trauma. It's a very important chain of the trauma chain of survival, and it starts, of course, with the pre-hospital phase, the recognition, and the triage. Major trauma centers play a very, very important role in this, and they have a central role in the trauma network, the trauma system, and they work together with other trauma units. This is an example of a major trauma center in Belgium. It is my alma mater. It's the Ghent University Hospital, which is a level 1 trauma center. It has 1,051 beds in total. So as I said, it's a level 1 major trauma center, and we have 350 traumas every year, more or less. And we do not have a trauma surgeon. And that is because in Belgium, trauma surgery does not exist on its own. Mostly they're self-declared trauma surgeons, orthopedic surgeons that do a lot of the blunt traumas. But in my opinion, I would not like an orthopedic surgeon to touch my abdomen when I have a ruptured spleen. So every discipline in Belgium does the surgery on its own. This also implies that there is a lack in a general trauma ward. So a lot of patients do not get the care that they deserve. They are admitted in the orthopedic surgery ward, and we have to make interconsultations with other disciplines to get the care that the patient needs. If you compare this with the Santo Tomas Hospital, it has 632 beds in total, and it is also a level 1 major trauma center with 250 admissions on the trauma ward. This is not the number of the total admissions of trauma in the Hospital Santo Tomas. There are a lot of patients that go directly home or that are transferred to another ward. And the patients that are observed in our ward for 24 hours and are then transferred to another ward are not taken into account. So you have at least to add up 100 to 150 patients more. So I'm looking at Dr. Mon if it's correct. And here in the Santo Tomas Hospital, we have one trauma surgeon. And it is official trauma surgeon, I have to say like that. It is Dr. Chiodetis. She went to Miami to do a major in trauma surgery for 2 years, and that makes her the only official trauma surgeon, actually in Panama as well. And she's surrounded by a team of general surgeons like Dr. Mon, Dr. Mohinani, Dr. Chavez, and Dr. Liao. And so at this moment, you already know a little bit of the differences and similarities between Panama and Belgium. But the biggest difference is that in Belgium, we really like protocols. Everything is put on paper, and we have one for every step in the trauma survival chain. So let's go through these protocols. The pre-hospital phase. In Belgium, on scene, everybody calls 112, and it's equal to the 911 system here in Panama. And based on the information of the call, they can send out different types of transportation. So we have an ambulance, a PIT, and a MUG. An ambulance is with 2 drivers that have their basic life support education. It's 160 hours of education that they have to follow. So they can take a patient from a scene and take it to another, to a hospital, and admit basic life support. The BIT is with one BLS driver and one nurse that has like special, she can administer drugs with standing orders, but she cannot do everything that she wants. And then we have the MUG, and the MUG is the most specialized transportation that exists. It contains a nurse and a doctor who are both advanced life support caregivers. And the important thing is that it looks smaller, but it is the one with the most expertise. It's always accompanying one of the others, the BIT or the ambulance, to transport the patient. MUG, if you translate it it's a Flemish word. If you translate it in English, the meaning is mosquito. So now you learned a little bit of Flemish as well. And this is everything that is inside the MUG. You can see the nurse and the doctor on the floor. There is even a surgery kit, so they can perform surgery on the field. It rarely happens, but they can. So now we picked up the patient, and where do we have to go now? It's not the best quality flow chart, but the message is very important. So when a patient needs to be admitted to a trauma hospital, you start with step 1. You look at the vital signs and at the level of consciousness. If the Glasgow coma scale is less than 14, the systolic blood pressure is less than 90, and the respiratory rate is less than 10 or more than 29, you have to transfer the patient to a trauma hospital, a level 1 trauma center. If not, you have to assess the anatomy of the injury. For example, all penetrating injuries to head, neck, torso, and extremities proximal to the joints, to the elbows and the knees, have to be admitted to a trauma hospital. If not, then you go to the third step. And the third step is to go back, is the mechanism of injury. So, for example, falls higher than 20 feet for adults and higher than 10 feet for children have to be admitted to the trauma centers. If they do not, if they don't have one of these mechanisms, then you have to look at step 4, special patient and system conditions, like the age, older patients, and as well younger patients, the children. Should be triaged preferentially to trauma centers that also take into account children. People who take anticoagulation or have bleeding disorders, you might take them to a trauma center as well. It doesn't have to be a level 1 trauma center, it can be a trauma unit because we're already in step 4. But the most important message is that when you're in doubt, you have to transfer to a trauma center. In Belgium, of course, we do have a form that needs to be filled in before transferring the patient. It's another protocol, but it's more or less the same as the flow chart in the previous slides. And then in the hospital, the trauma system, the people who pick up the patient, they have to alert the hospital with adequate information about the patient, and after that, an automated call goes out to the whole trauma team. And in our case, the trauma team involves the coordinating surgeon, the anesthesiologist, the emergency department, of course, radiology, a neurosurgeon, orthopedic surgeon, and the critical care, the head of critical care. And it looks a little bit like this. So you can see an A doctor that is that has to take the airway into account, an AB nurse, that's the one in green, a BC doctor, and a C nurse. The team leader is always standing at the feet of the patient, and that's mostly the emergency doctor or the intensivist. And then the people that are on the sideline that you don't see are the coordinating surgeon and anesthesiologist, the radiology department, orthopedic surgeon, neurosurgeon, and other disciplines. If it's a child, then it's pediatrician as well. They all have to wear jackets with their significant role on top of it with specific colors that everybody knows each other and knows who has which role. And then the patient arrives in the hospital and we have to do a handover, and it's following the ATMIST protocol as well. So in less than 2 minutes, you get a lot of information. It's about age, time, the mechanism of injury, the injuries that you see or that you suspect. You give the signs of the patient, the vital signs, and you also tell the treatment that has been already given. And now, after all the protocols, your trauma patient, okay, you got the handover via the ATMIST protocol, and what now? Does anybody of you have an idea what we should do now? Your patient is laying on the bed and doesn't look very good. Might as well die if you don't answer.
You secure the airway.
What did he say? Would you go directly for CT scan?
Fast.
A fast? Okay. I heard something else.
Secure the airway.
Indeed. We go for the A, B, C, D, E. Secure the airway. So just a quick reminder, A stands for airway, B stands for breathing, C is for circulation, D for disability, and E for exposure. And let's start with the airway. I will go over this quite quickly because I think that this is quite common knowledge. So in A, we need to assess and secure the airway of the patient if necessary. A quick assessment can be done by asking the patient something. If he replies with a normal voice, you can be sure that he has a clear airway. If not, if he's unresponsive or makes weird noises, firstly aspirate, check the mouth for strange objects, perform a chin lift or jaw thrust, and if there's doubt about the patient's ability to maintain his airway, we need to perform a definitive airway. You still know what a definitive airway means? Is larynx mask a definitive airway? No. Okay, so you only have 3 types of definitive airways. It needs to be past the vocal cords. So an orotracheal tube, a nasotracheal tube, or a surgical airway, meaning crical or tracheostomy. If we go to the B, it's very important to look, listen, and feel. Check if the patient's chest is going up symmetrically, if he's tachypneic, if he uses secondary breathing muscles, if you hear bilateral normal breathing sounds, if you feel subcutaneous emphysema, it feels a bit like crackling snow underneath. I'm not sure if you experience it here in Belgium. We have it often. And then you can do percussion as well, if it's tympanous or sonorous. So yeah, you check the saturation of the patient, very important. And we can also take an arterial blood gas. It's important in this step that you administer oxygen as well. And the injuries that are most important to recognize in the primary survey is a tension pneumothorax, flail chest, sucking chest wound or open pneumothorax, and a massive hemothorax. The others you will probably find out in the later steps of the trauma management. And then we go to the C, where cardiac frequency and the blood pressure are very important parameters in defining if a patient is or is not in shock. But what does shock mean? The definition is that this is the inadequate distribution of the circulation system that causes malperfusion of the organs and tissues. And most importantly is to recognize the shock and then define what type of shock you are dealing with. How to recognize it? First, there are early and late signs, and one of the early signs, actually one of the first signs, is that the patient will be restless, anxious, might be a bit in panic as well. Second is that you have to check the skin. The patient can be a bit clammy, can feel cold on the extremities. And thirdly, it will be the heart rate. The heart rate will rise. And then the late signs are the blood pressure, if the patient goes unconscious, and an altered respiratory rate. Urine output, a decrease in urine output is one of the later signs that will that you can check. And the different types of shock. Shock can be divided in between volume and output related. If we go to the volume side, it can be due to a shift, and that is called a distributive shock, or a loss in volume, and that is a hypovolemic shock. The distributive shock, examples of that are a septic shock or an anaphylactic shock, where your intravascular fluids go to the extravascular spaces. In the case of hypovolemic shocks, it can be hemorrhagic or non-hemorrhagic, and it can be traumatic and non-traumatic. An example of a non-hemorrhagic traumatic hypovolemic shock is, for example, a patient with a lot of burns. If we go to the output part, it can be intrinsic and extrinsic. Intrinsic means that it's due to arrhythmias or myocardial causes, and extrinsic means that there is some sort of obstruction, that the preload or afterload will be adapted, diminished, and that causes this type of shock. It's called the obstructive shock. An example of this is a pulmonary embolism, in which the ventricular afterload goes extremely up, and that causes the obstruction of pumping the blood forward. In case of hemorrhagic, or in trauma cases, the hemorrhagic shock is the one that is most prominent. It accounts for at least 30%. Non-hemorrhagic shock will be mostly obstructive. You have the cardiac tamponade and the tension pneumothorax. And in this case, if it's hemorrhagic, it's quite clearly. So there is a mnemonic for which you can easily remember the places from where the blood can come, and it's called blood on the floor and 4 more. Do you know this mnemonic? Okay. So what would the 4 more be? What spaces in the body would be abdomen indeed, thorax, pelvis and retroperitoneum, and extremities, the long bones in the extremities. For example, a femur fracture, you can lose at least 1.5 to 2 liters blood because of that. Very good. So now we can identify the 4. No, we know what 4 more are, and we know what shock is, but how can we identify it? What aids us into identifying these types of trauma? And then imaging is very much in handy. And then we will go over to the FAST and the CT. The ultrasound is very important. X-ray is very important. Those two you can do in the emergency department. And the CT scan, mostly you need to leave the emergency department and transfer the patient to another room. In some trauma centers, they have a very fancy CT scan in their emergency department, but unfortunately, nor here, neither in Belgium, that is the case. So I will show you a video of a fast ultrasound. It takes 1 minute. Yeah, it's with sound from the computer, of course. I have this on max volume, but I'm not sure if you will be able to hear this. Or can you adjust? I will start over. Yeah? checking. In the abdomen, he's going to the right hypochondrium first. He already checked it. He's checking for free fluid between the liver and the kidney. He checked the epigastrium for the cardiac tamponade. And now he's checking the left hypochondrium to check if there's free fluid between the kidney and the spleen. Suprapelvic, to check if there's free fluid in the Douglas space. And then he checks he checks the thorax for pneumothorax or a hemothorax. I'm not sure if you know. I'm not sure if you recognized at the end the lines. So if we check the thorax here, you can see the pleura over here, and normally you can see it slide back and forth. You saw it on the video. If you're not sure that you can see it very properly, you can put the ultrasound in M mode, and then if you get the C and H waves, then it's normal. If it's not like that, then it's probably a pneumothorax. So it was a very fast video. I couldn't even talk through it because it was faster than me. And that's the point of a fast. It needs to be quick. In less than 1 minute, you have information about the thorax and the abdomen, 2 of the 4 causes that can cause a hemorrhagic shock. And of course, a pneumothorax and a cardiac tamponade that can cause an obstructive shock. Anybody knows what's the difference between a fast and an E-fast? In an E-fast, in an E-fast, you will add 2 points of vision in the thorax to check for hemorrhage as well. So instead of going apical and in the mid-clavicular line, you will check in the 4th or 5th intercostal space, mid-axillary, to check for fluid, and you can also see the pleural sliding as well. So now some exercises. What do you see here? Yes, is this a normal or an abnormal ultrasound? Abnormal. Who says normal? Raise your hand. Very good, it is indeed abnormal. There is a large effusion. You could see the right atrium, left atrium, and the left ventricle. The right ventricle was compressed due to the external compression of the pericardial fluids. So it was cardiac tamponade. Next one. What do we see here? Liver and lung, indeed correct. Is this normal or abnormal? Abnormal. Yes, it is. What do you see? It is a large hemothorax. Next one, what do you see here? Kidney, yes.
And the liver.
Spleen, indeed. Is this normal or abnormal? Abnormal. Indeed abnormal. There's free fluid intra-abdominally. If we go to a chest x-ray, if we want to address a chest x-ray, we will always check for the lung fields on the right and the left. We will check if we have clear views of the costophrenic angles on the left and the right. If you're checking that one, you can also see if there is free air underneath the diaphragm. You will look at the mediastinum, if it's widened or not. You will look at the trachea, if it's displayed to one side or another, or if it's in the middle. And you can also check for fractures, rib fractures. But most times you don't see them very, very clearly. Okay, so now you have this information. We will do some more exercises. What do you see? It is a pneumothorax, but in this case, probably a tension pneumothorax because the lung is completely collapsed. And what do you think of the quality of this X-ray? Bad, indeed, because you cannot see the costophrenic angles, you cannot see the clavicles, you cannot see or you can see the trachea, but not completely. It is deviated to the right. So it was tension pneumothorax. Next one. What do you see here? It's a bit more difficult because the quality is not as good as well. But you can indeed see on the right side that the cosophrenic angle is completely gone and that it's filled with fluid. So we have a hemothorax. You know what to do when you have or a pneumothorax or a hemothorax?
Yeah.
Yes.
Pleural
Huh?
A pleural tube.
Yeah, indeed. You can perform a thoracostomy and put a drain inside to relieve the air or the blood. If there is 1 liter coming out of the chest tube, what would you do? I would wait a bit more. If it would be 1.5 liter, clamp the drain, then it doesn't come out all the time. Next one, this is a bit more difficult. What do you see here? It is a patient of Dr. Mott. Indeed, what can be the causes of the widening of a mediastinum?
Section.
Okay, what else?
Cardiac tamponade.
Yes, can be as well. Did you hear what she said? No. Cardiac tamponade, and the first one is an aortic dissection. What else is in the mediastinum that can be affected during trauma? We use it every day, but your esophagus. It can be ruptured, and this was a case in this patient. He had a ruptured esophagus with a mediastinitis, a large collection inside the mediastinum. So it's not always the clear and first-hand causes that you have in mind that will be the answer on the question. So keep those in mind as well. What if there would be some air as well in the mediastinum? What can be the causes for that one? The rupture of trachea, the primary bronchial structures as well, and the esophagus again. Okay, so we learned how to identify the bleeding, but how do we know the severity of the bleeding? If the patient would be in need of an operation or an intervention or not. Then this table comes in handy, and it's an overview of the different classifications of hemorrhage. And again, you can see that blood pressure is one of the later signs that is affected due to hemorrhage. Anybody knows what pulse pressure is? Pulse pressure? It is not the tactile pressure that you feel when you're feeling for a pulse. It is the difference between systolic and diastolic pressure. And like in a normal person, if he has a pressure of 120/80, the pulse pressure is 40. But mostly in trauma, when you see that the blood pressure will diminish, the pulse pressure will go down as well, and it will go down earlier than the blood pressure itself. For example, trauma patient can have blood pressure of 110 100 over 75, and then the pulse pressure is diminished in comparison with a person with a normal blood pressure. So the physiologic reactions are linked to the loss of volume. And in class 1 you have a less than 15% loss, class 2 you have 15 to 30%, class 3 you have a 31 to 40% loss, and in class 4, the most severe, you have a more than 40% loss. And this, this volume needs to be substituted. What will you administer firstly? You will go for blood straight ahead? You can give indeed 1 liter of saline infusions, but after that a patient will definitely need blood in class 3 to 4 hemorrhages. In class 2, not necessarily, depending on how the trauma evolves and what the trauma mechanism is. And in class 4, you can see that your massive transfusion protocol is outlined. Are you familiar with a massive transfusion protocol? No. Okay. It's good because I wrote it down. So the definition is a rapid administration of large amounts of blood products, at least 6 of packed red blood cells in fixed ratios. And ratios are 1:1:1. Do you know what I mean by the 1:1:1?
Yes.
Okay, so it's red blood cells, fresh frozen plasma, and platelets. You can use the ABC score to determine if you have to start the massive transfusion protocol. It depends on the systolic blood pressure, heart rate, a penetrating torso injury, and a fast. For each one, you can get a point, and if it's less than 2, you probably won't need the massive transfusion protocol. If it's 2 or more, you might start it. I don't know if it's a thing that you will encounter a lot, but I think it's handy that you know about it. And actually, the massive transfusion protocol is one of the only protocols in the Santo Tomas Hospital, and one of many in Belgium, of course. So you see that it's based on the ABC rules, and then the administration of the blood products. So if you have a patient with class 4 hemorrhage who needs fluid resuscitation, you will start with 1 liter saline solution. Mostly, or like in Belgium, they already address this pre-hospital. And then in the hospital, you will do the blood transfusion, as I said before, 1:1:1, but you can also do 2:1:1. It does not mean that you give 1 bag of red blood cells, 1 bag of platelets, and 1 bag of fresh frozen plasma. It means that you have to administer units, because 1 pool of platelets contains 4 bags, so you will need to level up the other ones as well. You can give tranexaminic acid only in the acute phase. If you administer it in the later phase, it can cause embolisms. And how can you evaluate if you're doing your fluid resuscitation correctly? That's via a blood gas analysis where you check the hemoglobin, the pH, the base deficit, and the lactate, and also a thromboelastogram. I will not go into this further because it's a whole class on its own, but just keep in mind that if it's normal, it should look a bit like a bullet. And then you can also see that I wrote permissive hypertension. In cases where you have severe bleeding, you don't want the blood pressure of the patient to be normal, because he keeps on bleeding. He loses everything that you administered before. So that's why we say permissive hypertension, keep a mean pressure of 60 to 80. That's more than enough. And so based on your findings while evaluating your fluid resuscitation, you can divide your patients into categories. You have rapid responders, in which their vital signs will return to normal. You have transient responders, where you have a short improvement, but then you see the blood pressure going down again. And you have the minimal or no responders, where the vital signs remain abnormal. And in the transient responders and in the minimal to no responders, the chance for an operative intervention, or the need for an operative intervention, is likely and highly likely. Because you can administer liters of blood, if you don't address the cause, your patient will still die. So this is the most important message: stop the bleed. If it's obvious bleeding, you can apply direct pressure, or apply a dressing and press, or apply a tourniquet if it's in one of the extremities. But this does not take into account the other 4 bleeding causes. causes. And for that, we will need to go to the operating room. And then damage control surgery is one of the important things. It is to skip or diminish the cause of death by the triangle of death or the diamond of death. Do you know what the triangle of death or diamond of death is? Acidosis, hypothermia, coagulopathy, and the fourth one that we oftentimes forget, hypocalcemia. So damage control surgery means that your surgery needs to be as short as possible, that you have to go in quick and dirty. It will be dirty, but it also needs to be good. And then we have this, empacar y correr. You open the abdomen with a midline incision, you have a massive bleeding, you don't know how to handle it, or you know how to handle it, but the blood comes like a lot at a time. So you pack the patient into the 4 quadrants, and after that you leave the wound open. But what with an open wound? What to do with an open wound? You can put in a Bogota bag that keeps the inside protected from the outside. And you can also see on the right flank that there's an ostomy. That is also one of the techniques that you can administer during damage control surgery. Oftentimes you will just defunctionalize the bowel if you have a perforation of the small bowel. Then you resect the segment that is affected, and you just leave it like that. Because if you leave the abdomen open, you will have to go back and re-explore a few days later to depack and to check the evolution of the abdomen. The empacar y correr is more for solid organs, and the defunctionalizing is more in the hollow organs. You cannot pack a hollow organ when it's punctured, because then your patient will definitely get into a distributive shock, sepsis. And what else can you do besides operating? Not operate. In 25% of the lesions due to gunshot wounds, you can stay conservative. In 30% of the stab wounds, and in more than 50% of the blunt traumas, you can stay conservative. But you always have to keep the patient, keep an eye on the patient. For example, this patient was a young female patient that got a gunshot wound in the right hypochondrium. What is in the right hypochondrium? What could be affected? The liver, indeed. And that was indeed the case for her. She had, you can see the darker, you can see that it's a bit darker on the CT scan. But you cannot see free fluid. You cannot see an active bleed, and the patient is hemodynamically stable. So you can admit her to the trauma ward and keep a good eye on her, give her supportive therapy, and follow up on vital signs, blood gas analysis, etc. If anything changes, if her vital signs change, if she has abdominal pain, you have to start all over again, A, B, C, D, E, and reassess to check if you need to alter something in your therapy. I put this slide in as an extra just so you know that there are different gradings in solid organs in trauma, and that the higher the grade, the more likely you will need a surgical intervention. If this would be the CT scan of the lady before, we're lucky because now it's it's already on the slides. It's an aneurysm of the common hepatic artery. What would you do? Would you still treat her conservatively? Like watch and wait? Keep an eye on her? What would you do? Would you go to the operating room? Who would go to the operating room for a midline incision, for packing, and what else can we do?
Endovascular.
Indeed, endovascular treatment. In this case, they put a stent, which has a very, very nice result. They didn't even have to compromise the left or right hepatic artery. It was only in the common hepatic artery. And for splenic injuries, you can also put a stent, or you can do coiling. You can also do percutaneous interventions in later phases of the trauma management. If someone, after a trauma, develops an abscess or a collection, it can also be drained percutaneously. And then I put this slide in just to be complete, that we have the ABCDE assessment. Mostly, if you have a trauma patient that needs surgery, this will be addressed in the intensive care unit. So you have to assess and protect the brain and spinal functions. Don't forget glucose, it's very important as well. And the exposure, the most important thing here is to avoid hypothermia. So then I come to an end of my presentation with some take-home messages. ABCDE is very important. Trauma surgery is not difficult, you only have to learn the alphabet. ABCDE for the assessment of a trauma patient, ABC for the massive transfusion protocol, and you will be on a good way. Shock, very important that you know how to identify, how to classify, and how to act accordingly. Reanimation, the massive transfusion protocol, don't forget it. And permissive hypotension is one that tends to be forgotten quite often, but it can save a life. You can do whatever reanimation you want, but you need definitive control of the bleeding to save your patient. So damage control surgery is very important. And keep in mind that in trauma, or that a treatment is always patient-specific and trauma-specific. Not any case will be completely the same. And as we say in Europe, all roads lead to Rome. It's a little bit the same in trauma. Sometimes you just need to take a detour. So if you have questions, you can do it in Spanish if you don't feel comfortable in English. I understand quite a lot. And if not, I have my personal assistant and translator with me, Dr. Hall. Yeah.
Habla en español para que todos sepan, entiendan.
En el caso de los endotórax, yo voy a quitar el drenaje cuando ya tengo certeza de que hay un sangrado puro, o cuando ya la medida me dice que es mayor de 1 litro o mayor de 5 litros.
¿Qué quieres decir con quitar el drenaje?
O sea, detener el drenaje en un neumotórax.
O sea, tú pones un tubo, es lo que estamos diciendo, y va a salir sangre.
Exacto.
Pero en algún momento tú estás preguntando si vas a pinzar el tubo.
Exacto.
Okay, so you get that?
Yeah.
Okay.
It's not that the cutoff is exactly 1.5 liters. You can check, but mostly if the patient bleeds for more than 1.5 liters from his chest, he will probably need further intervention. I don't think that the patient will be hemodynamically stable, so the next step will be to take him to the operating room. It's just to avoid that he will bleed out, that you put a clamp on it. Because if it would be an aortic rupture or a rupture of the pulmonary artery or vein, it's not going to stop. It will keep coming. Another question? Now is the time to ask questions. There are no stupid questions. Just ask. Yeah.
¿Cuál es el mecanismo de acción del ácido tranexámico? ¿Para qué sirve?
Yeah. Technical question. Thanks. I don't know exactly. I don't know if Dr. Mon knows. It just helps in the coagulation when you have a bleed, and it's proven that it's effective in the acute phase of a trauma. In Belgium, we also administer it in the following days if you have a patient that is not bleeding. A lot of it has like the diffuse bleedings. We also use it, but there is a higher chance of thromboembolisms.
El ácido tranexámico es un antifibrinolítico. Entonces, tendríamos que poner aquí la escala de la coagulación para ver exactamente el sitio donde va a actuar, si ese es lo que te está interesando. Pero básicamente, aunque se usa, como dice Liz, aunque se usa en muchas ocasiones de una manera empírica, en teoría uno debería tener alguna evidencia de que esto va a funcionar. Y esa evidencia usualmente se va a conseguir a través de un tromboelastograma. Pero como sabemos que existen algunas situaciones en las que esta situación de la hiperfibrinolisis es común, entonces lo utilizamos empíricamente en mucho. La cirugía cardíaca es uno de los primeros casos en que eso se usa. Claramente, si el paciente tiene evidencia tromboelastográfica de fibrinolisis, también se usa. No me sé el sitio exacto, pero estabiliza el coágulo para que no ocurra fibrinolisis, para que la fibrinolisis no destruya el coágulo que se está formando y persista el mecanismo y persista el proceso hemorrágico.
Do you know how long you have to wait for a thromboelastogram to come out completely? You have a first assessment if they're quick after 30 minutes, but you don't have the definitive numbers. That only comes after 1 hour, 1 hour and a half. So that's the reason I said it. Oftentimes you administer it empirically.
Creo que en el Santo Tomás lo podemos hacer, pero lo que se está tratando, como lo presentó Liz, es una imagen, básicamente, y por eso siempre hacen tanto énfasis, y ustedes van a ver por todos lados que algunos lo han comparado con distintas copas de vino, y a los que les gusta el vino verán que hay algunos que te dicen la copa de champaña, la copa de qué sé yo, la copa de un martini que no es vino, pero no importa, porque en teoría uno podría ver cómo se está formando la imagen y tener una idea de qué es lo que está pasando antes de tener los números. Entonces, yo creo que en el Hospital Santo Tomás ya lo podemos hacer, pero de seguro que en algunos lugares sí lo están haciendo. Y básicamente lo que hay es una pantalla en el sitio donde sea que se está atendiendo el paciente. Y esa pantalla lo que está es transmitiendo la imagen, cómo se va formando a medida que va realizándose la prueba, que es lenta. Es un poco lenta, no es una prueba de cuarto de urgencia, claramente no lo es, pero es una prueba muy, muy, muy útil. Y uno lo ve, uno va viendo ahí qué tipo de forma va cogiendo la imagen.
No, pero la otra pregunta es, cuando yo cojo un lavado peritoneal a un ultrasonido fast, ¿cuál se hace más rápido?
That's for you.
Okay.
Did you get that? Yeah, he wants to know when does he do a diagnostic peritoneal lavage versus an EFAS?
Never. We never do it anymore because for an EFAS you will get free fluid in the abdomen when you have about 150 to 200 cc. For a peritoneal lavage, I think you need more, plus it takes more time than a fast. You can do the fast in 1 minute. If it's a big patient, for the peritoneal lavage, you will need more time. So fast is very, very nice to do. And if it's positive, the patient is unstable, you go to the operating room. If it's positive, the patient is stable or is a transient responder, he's stable at this moment, you take him to the CT scan. The peritoneal lavage, I don't know if you still perform it, but we completely deserted that.
La pregunta es, o sea, ¿dónde viene esta pregunta?
Lo dimos en la clase, dimos una clase similar.
Ok, realmente, como dice la doctora, Yo creo que el lavado peritoneal diagnóstico actualmente tiene un interés histórico. Esto no es algo que sí se puede hacer y lo hacemos. Y cuando yo era residente, nosotros teníamos unos sobrecitos en que venían unas pincitas y cosas de estas, y todos los días yo empezaba un turno con 2 de estos en el bolsillo de la bata, porque era lo que hacíamos, el lavado peritoneal diagnóstico, y funcionó muy bien, pero hay que conocer la historia, porque el lavado peritoneal diagnóstico vino como una mejor técnica de lo que se llamaba la punción abdominal en 4 cuadrantes, que básicamente era que metíamos una aguja aquí, otra aguja aquí, otra aguja aquí, otra aguja aquí, y aspirábamos a ver si salía sangre, y se hizo, y a veces salía sangre, y a veces perforábamos el intestino, o a veces le pegábamos al hígado, y entonces el paciente no estaba sangrando, pero ahora sí está sangrando. Entonces, como esa técnica era tan agresiva y de tan poca sensibilidad y especificidad, vino lo del lavado peritoneal diagnóstico, y el IFAS es probablemente la consecuencia lógica de ir progresando en el diagnóstico del trauma. Pero sí, realmente, aunque se puede hacer y no es nada complicado y es fácil, no lo hacemos casi. Yo este cuento lo cuento porque es verdad, pero la última vez que yo hice una de estas cosas fue hace 20 años, no me acuerdo. Fue una paciente que el neurocirujano quería de una manera extraordinaria que determináramos si el líquido que estaba dentro del abdomen era sangre o era alguna otra cosa, porque él quería llevar a la paciente al salón de operación. Y hace 20 años, por supuesto, no teníamos los recursos que se tienen ahora, así que ahí eso es lo que se hace y lo que se hizo. Pero ya, eso fue hace un montón de tiempo. Después de eso, no recuerdo que hayamos hecho, yo por lo menos un curso. ¿Alguna otra pregunta?
False ultrasound has a very high sensitivity. It doesn't have a very high specificity because you don't look long enough, but it has a very high sensitivity too.
Ok, yo tomé unas notas de la charla breve, pero era una cosa muy sencilla y que yo creo que es bien importante que enfaticemos. Lo primero es que hace un montón de tiempo yo tuve una reunión con una doctora que venía del Educational Commission for Foreign Medical Graduates, y ella vino aquí a hablar cuando comenzaba lo del examen de certificación, y ella vino aquí a hablar de cómo hacer esto, cómo elaborar los exámenes, cómo hacer una serie de cosas. Y yo recuerdo muy bien, y es mi experiencia personal de cuando a mí me tocó hacer estos exámenes hace muchos años, que ella dijo, a nosotros, ¿qué nos interesa que sepa el médico interno? Y es básicamente esta clase. A ustedes nadie les va a pedir que diagnostiquen como médicos internos un cáncer de colon. No importa. No lo diagnosticaste, ese no es tu trabajo. Y la mayor parte de las veces ustedes van a tener apoyo en el momento en que tienen que tomar decisiones importantes, menos en esto. Aquí a las 3 y pico de la mañana puede ser que no haya nadie más. Y son ustedes los que tienen que tomar esas decisiones si están en el cuarto de urgencia. Entonces, es interesante porque aunque quizás no le damos la importancia y lo vemos algo como, yo nunca voy a hacer esto. Hay algunos de ustedes que están aquí, probablemente la gran mayoría, nunca más van a volver a oír hablar de esto. Nunca. Porque no van a rotar por trauma, no les va a tocar un caso, nunca más van a volver a oír hablar de esto. A menos que tengan mala suerte y entonces les toque y no sepan qué hacer. Por eso es que esta clase yo pienso que es supremamente importante. Y por eso la hemos elaborado de esta manera. Entonces, la otra pregunta que también lo tocó la doctora, pero ¿cuál es la principal causa de muerte en el paciente politraumatizado? La primera causa, no principal. Principal es un término medio ambiguo. La primera causa, la más frecuente, es que se muere la gente que tiene un trauma politraumatizado. No. No.
Trauma craneoencefálico.
Trauma craneoencefálico. La primera causa de muerte es trauma craneoencefálico. Fíjense que aquí viene un juego de palabras que a veces se los ponen para confundirlo, pero ustedes no se van a dejar confundir, porque ustedes ya estuvieron aquí. El juego de palabras es, ¿y cuál es la primera causa de muerte prevenible? Porque si a mí me meten un hachazo en la cabeza y me muero, yo no creo que eso era salvable. O si de repente me estrello y tengo una hemorragia epidural severa, eso no era salvable. Pero ¿cuál es la primera causa de muerte prevenible? Hemorragia. Entonces ahí hay un jueguito de palabras. No es la primera causa de muerte, pero es la primera causa de muerte en la que uno puede actuar. Y eso es importante que lo recuerden. Y la doctora lo presentó también en su presentación. Y ella dijo, la primera, ¿dónde está? O sea, la primera causa, ¿dónde están las hemorragias? Perdón, no es la pregunta, no es así. La primera causa, el primer sitio donde la gente se muere es en la cabeza. ¿Y dónde es el segundo sitio donde la gente se muere? En el tórax. Eso también es supremamente importante, porque si ustedes tienen un problema, si tienen una duda, y es común encontrarse con un paciente que está en shock, y yo no sé de dónde viene el shock. A pesar de que me sé esa regla de on the floor and 4 more, yo todavía tengo que saber cuál de esos 4 es. Entonces, no se les olvide nunca el tórax, porque ahí están los hemotórax masivos, ahí están los hemotórax de tensión, ahí están las rupturas aórticas, que no todas son mortales. La mayor parte de los pacientes con una ruptura aórtica mayor se van a morir en el sitio, pero van a llegar pacientes así con el mediastino ensanchado, con una ruptura de aorta, que no van a estar muertos y van a estar bastante estables. Y ahora con la imagenología vamos a diagnosticar muchas más. Tanto así que hay algunas ya que el manejo es conservador, no le hacemos nada. Pequeñas lesiones, pequeñas laceraciones, pequeñas disecciones, son rupturas de aorta, pero no les hacemos nada. El punto es que hay que estar pensando en esta situación de que las causas de muerte hay que ir al tórax cuando estamos en duda. Con respecto a lo del tromboelastograma y la otra cosa que mencionó la doctora de la anticoagulación, nada más decirle que esto está de moda. Tienen que saber de esto. La cantidad de gente que anda por ahí anticoagulada o con algún tipo de inhibición plaquetaria es enorme y cada vez va a ser más. Entonces ustedes tienen que saber de esto. Tienen que saberse cuánto es el tiempo que dura el apixaban, tienen que saberse cuál es el antídoto, si es que lo hay, esa es pregunta de examen, si es que lo hay para el apixaban o para el rivaroxaban, o cómo antagonizo la heparina, cómo antagonizo, se lo tienen que saber, eso es parte de las cosas que ustedes tienen que conocer, porque se las van a preguntar en unos exámenes, porque son cosas que se presentan con mucha frecuencia en la práctica clínica. Y eso nada más es para enfatizar algunas de las cosas importantes de la clase. Con respecto al manejo no operatorio, Nis lo dijo, pero a la gente se le olvida. El manejo no operatorio tiene varias condiciones sine qua non. Tiene que haber un cirujano. Si ustedes están en un lugar en donde no hay un cirujano, ustedes no pueden intentar manejo no operatorio, porque si falla, ¿qué hacen? Entonces tiene que haber un cirujano. Pero igual, alguien escribió una vez en un periódico, yo le dice que un médico sin recursos es un curandero glorificado. Entonces el cirujano tiene que estar ahí, pero tiene que tener un salón de operación. Porque yo, en media calle, en Nice, entre Panamá y el Valle de Antón, el cirujano, pero si alguien le pide que haga algo, pues no podemos hacer nada. Entonces, un cirujano, un salón de operación, tiene que haber facilidades de imagenología sofisticada. Ultrasonido no es suficiente. No puedo hacer manejo no operatorio porque tengo un ultrasonido y vi un poquito de sangre y me parece que hay una laceración en el vaso. No. Idealmente tengo que tener facilidades de hemodinámica o de terapia no operatoria como lo presentó Nis. Si yo no tengo estas 4 cosas, yo no debo intentar hacer tratamiento no operatorio. Y a la gente se le está olvidando porque todo el mundo está oyendo hablar de esto de manejo no operatorio y mucha gente no tiene claro qué es lo que significa y cuáles son sus implicaciones. Dame un pedacito que estoy en una clase, a mucha gente están un poquito confundidos y creen que esto significa que no tengo que operar a nadie. Y esto tiene que estar claro. ¿Qué es lo que está pasando en Panamá en este momento? Lo que está pasando es que mucha gente comienza el manejo no operatorio y después lo traslada. Y eso no está mal. Eso no está necesariamente mal. Idealmente yo debería hacerlo en un solo sitio, pero si no se puede, uno busca, siempre y cuando el paciente esté en condiciones de ser trasladado, uno busca mover al paciente a un sitio donde haya esto. Ahora mismo, si me preguntan, yo no estoy seguro si el Hospital del Niño tiene hemodinámica. El Hospital Santo Tomás sí tiene, la Caja de Seguro Social claramente, la Ciudad de la Salud también, y ya. Y fuera de los hospitales privados, en los cuales hay todos los recursos, pero falta ver si hay quien lo haga y si se hace oportunamente, porque todo esto, volvemos a lo del FAS, como dijo la doctora, el énfasis en esto es que esto es rápido. Esto no es diagnóstico del cáncer de mama, esto no es diagnóstico del linfoma, que toma 3 a 4 semanas después de haber hecho la biopsia, porque hay que hacer un poco de montón de pruebas de inmunohistoquímica. No, esto es rápido. Me imagino que en su clase les hablaron del periodo de oro, del golden, lo que sea. Entonces, estamos hablando de un periodo que todas estas cosas deben ocurrir en un máximo de 2 horas. En un máximo de 2 horas uno tiene que tener una idea bien clara de para dónde va este paciente. Y tiene que tener los diagnósticos bastante bien definidos. Entonces, de nuevo, revisen esto. ¿Le vamos a dar la clase, no? ¿Are they getting the PowerPoint? Okay, so ya ustedes la están grabando, pero el que quiera puede tener el PowerPoint, revísenla. No sé si va a venir algo de esto en los exámenes. Nosotros no participamos en la confección de ningún examen, pero sí va a venir en el examen de la vida. Eso que tenganlo por seguro que ahí va a venir. Y ese como digo a mí, ese es el momento en que uno no puede decir, ups, no me acuerdo. Así que, no sé, ¿alguna otra pregunta, algo más? Dígame.
Quería preguntar, en el interior no hay salones de hemodinámica, entonces.
Yo no sé si yo creo que en Chiriquí, fuera de eso no. Y el problema no es tanto que no haya, porque ese es un recurso que se compra, no es barato, se compra. El problema es el recurso humano. El problema es el recurso humano. Que de nuevo volvemos a lo mismo, o sea, manejo operatorio, que podríamos añadirle, eso ya lo haría más complicado, pero podríamos añadirle a la necesidad de tener un cirujano, la necesidad de tener un hemodinamista. Ahí sí tendríamos una situación bastante más complicada porque hay muchos cirujanos, muchos, más de la cuenta, hay poquitos hemodinamistas, muy poquitos, mucho menos de lo necesario. Entonces, un detallito ahí para que lo tengan para el futuro. ¿A qué me voy a dedicar? ¿Qué? Diga.
Más pregunta curiosa. ¿Qué diferencia o qué competencia adquiere un cirujano de trauma que por lo menos un cirujano general no pueda resolver?
You get the question.
What the difference is between trauma surgery and general surgery?
Esto es bien interesante, o sea, como dijo Nis, en Bélgica no hay cirujano de trauma. En Panamá hay un cirujano de trauma. En los Estados Unidos hay muchos cirujanos de trauma, pero esta no es una especialidad que existe a nivel mundial de una manera, por decirlo así, nosotros todos queremos tener cirujanos de trauma, igual que si queremos tener ginecólogos y pediatras. Por muchos años siempre se estableció que la cirugía de trauma era de cirugía general. Y todavía aquí en Panamá, excepto los días que está la doctora Giodetis de turno, es así. si el paciente llega en cualquier momento que no esté la doctora que de turno, lo va a atender un cirujano general. El cirujano general, y ahí estamos teniendo un problema grande porque hemos creado tantas subespecialidades que el cirujano general ya no existe. Pero en los hospitales como el Hospital Santo Tomás y en la Caja del Seguro Social más, porque allá no está la doctora Codet. Entonces allá son puros cirujanos generales. Y el problema que te digo es que en parte al irnos subespecializando tanto, hay algunas cosas que se han salido del ámbito de lo que aprende un residente durante su residencia. Cuando yo hice mi residencia en el Hospital Santo Tomás, yo veía el trauma todos los días, absolutamente. Ahora el residente ve el trauma en sus turnos y durante una rotación de 2 meses de una residencia de 5 años. Yo tuve 5 años de residente y yo hacía trauma todos los días. Si queremos ponerle, si la doctora que decía que habíamos invitado, pero digo que quizás yo no iba a poder venir, pero si tuviéramos que ponerle algo muy preciso, es la parte del manejo pre y postoperatorio. El cirujano de trauma usualmente tiene mucho más entrenamiento en los manejos pre y postoperatorios. Desde el punto de vista de operar propiamente dicho, no debería haber una diferencia. Porque nosotros igual, aún la doctora que si el paciente tiene una lesión en el corazón, hace y repara, pero llama al cirujano cardíaco. Si el paciente tiene una lesión pulmonar, hace y repara, pero llama al cirujano torácico. O sea, que no es que es un cirujano que opera todo, no. O sea, y tiene que saber algunas cosas de técnica quirúrgica muy particulares, pero no es muy distinto a lo de cirugía. En cuidados pre y postoperatorios, allí el cirujano de trauma tiene conocimiento mucho más avanzado que probablemente un cirujano general. ¿Qué ocurre en el mundo real? Porque al final de cuentas, de nuevo, volvemos a que aquí nada más, solamente en este hospital hay un cirujano de trauma. Lo que ocurre en el mundo real es que el cirujano general opera y consulta intensiva. Opera y consulta esto, opera y consulta esto, pero rarísima vez tú vas a encontrar al cirujano general atendiendo a un paciente en ventilación mecánica, requiriendo concentrado de protrombina y requiriendo vasopresores complejos. No lo va a ver. Eso usualmente va a haber alguien de cuidado intensivo involucrado. ¿Alguna otra cosa? Sí, Mario.